You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for October 19th, 2018. This week I'm talking low-dose rivaroxaban, high blood pressure, research misconduct, cybersecurity in cardiac devices, and bariatric surgery. First is low-dose rivaroxaban. The FDA recently approved low-dose rivaroxaban 2.5 milligrams every 12 hours along with aspirin to reduce major adverse cardiac events, MACE, in adults with coronary disease or peripheral artery disease. This is the first time a direct-acting oral anticoagulant has been approved for a major adverse cardiac event reduction in vascular disease, and it follows a similar approval in Europe. It's based on the COMPASS study, which was an RCT of more than 27,000 patients with stable vascular disease. Recall that COMPASS had three arms: the low-dose rivaroxaban plus aspirin, that's 2.5 BID plus aspirin, the 5 milligram rivaroxaban alone arm, and aspirin alone. The primary endpoint was a composite of CV death, stroke, and MI, and it occurred in 4.1% of the rivaroxaban aspirin group and 5.4% in the aspirin alone group. That's a 1.3% absolute risk reduction over 3-year follow-up, the NNT in the 70s. The 5 milligram rivaroxaban alone arm also had lower major adverse cardiac events compared with aspirin, but it did not reach statistical significance. Now, major bleeding occurred in 3.1% of the low-dose rivaroxaban plus aspirin group versus 1.9% in the aspirin alone group, and that absolute increase was 1.2%, or a number needed to harm of about 80 to 83. Intracranial or fatal bleeding was not increased in the rivaroxaban aspirin group. Now, my thoughts on this are similar to what I wrote about at the time COMPASS was presented. These are very small improvements in MACE. Now go look at the figure in the New England Journal of Medicine which shows the Kaplan-Meier curves. The curves are nearly identical. That is, unless you use this severely truncated y-axis, that little insert one where they truncate the y-axis. But the real absolute Kaplan-Meier curves are essentially identical. So in summary, the bleeding risk increase is about the same as the major adverse cardiac event reduction. The drug is twice daily, so you have to have more pill burden. It'll surely be costly. And two recent trials of rivaroxaban, Commander heart failure in patients with heart failure, and Galileo rivaroxaban after TAVR, failed to show benefit and moved toward harm in the Galileo trial. So despite the onslaught of free lunches that will surely be offered in my office in the upcoming weeks, I will remain a slow adopter of this flat-of-the-curve, low-value therapeutic intervention. Second topic is about the FAITH study. Aptly named, the FAITH study investigators set out to study the efficacy of community-based interventions for hypertension, and they did this in churches. Now, I should set out first that the FAITH study, unlike the Black Barbershop trial, studied non-pharmacologic interventions for hypertension. FAITH was a 2-arm cluster randomized trial conducted in 32 New York City churches whose members were mostly African descent. The authors actually randomized the churches, and one set of churches used a faith-based motivational interviewing and therapeutic lifestyle counseling intervention consisting of 11 weekly group sessions, and it focused on the adoption of healthy lifestyle behaviors, stress management, medication adherence, structured goal setting, and even tastings of healthy food. The health education group, the comparator group, participants received 1 lifestyle session on blood pressure management plus 10 informational sessions on health education topics that were led weekly by health experts. The primary endpoint of FAITH was change in blood pressure at 6 months, and the main results were that both interventions work, both lowered blood pressure. So 16.5 millimeters with a layperson-led intervention that targeted hypertension with science and elements of scripture, and by 10.7 millimeters of mercury with a general health education led by outside experts. So my comments are that although these blood pressure changes don't approach the 20 millimeter drop seen in the black barbershop study, they are still impressive results, and importantly, they happened with lifestyle intervention alone, whereas in the barbershop study, pharmacists actually prescribed meds, so you'd expect more blood pressure reduction with medications. But the biggest implication from faith in the barbershop study is the notion of community-centered healthcare. I mean, right now, healthcare is mostly doctor-centered. Patients come to us on our time. And that puts up barriers to getting important therapies, say blood pressure medications. Community-based care overcomes some of these barriers, but even more important, perhaps, is that non-white patients from different cultural and ethnic backgrounds may be more apt to follow health recommendations if it comes from their peers, like fellow church members or barbers. High blood pressure in black patients is a serious health condition, and new models of getting therapeutic lifestyle messages and basic blood pressure medicines to these patients could have massive public health benefits. I look forward to seeing new paradigms of care like this evolve over the coming years. I mean, so much in cardiology in recent years involves just marginal incremental gains, like the low-dose rivaroxaban study, for instance. But influencing and improving blood pressure in the many millions of black patients with hypertension would be possibly akin to gains seen from the reduction of smoking. In other words, these would be huge, huge gains. The next topic concerns research misconduct. One of the basic rules of cardiology is that once heart muscle dies, it is permanent. Scar replaces dead myocytes. The use of progenitor cells to either replace myocardial scar or induce regeneration of dead myocytes could have been the ultimate do-over. And early studies of stem cell therapy in cardiology looked promising, but clinical trials failed to confirm any benefit. And now, recently, Harvard and Brigham and Women's Hospital a call for the retraction of 31 published studies from former Harvard professor Dr. Piero Anversa. They determined that these 31 publications included falsified and/or fabricated data, and Brigham and Women's and Harvard have notified all the relevant journals. Now, the New England Journal of Medicine editor-in-chief, Jeff Drazen, wrote yesterday that New England has retracted a paper after Dr. Anversa's co-authors said they had no confidence in the reliability of the data. That is a huge deal because Dr. Anversa was a pioneer in stem cell therapy, and he was an award-winning researcher. His fraudulent work surely led to millions of dollars being spent on further studies. Now, while I think the vast majority of scientists are honest, these sorts of egregious cases of research fraud just crushes the public trust. And trust is so precarious, it's hard won, but so damn easily lost. I imagine that as long as humans do science, there will be these sorts of setbacks. But that said, I can't see how one can dwell on this sorts of news and oppose more transparency and openness in original scientific data. I also can't help but wonder about the vigor of policing of scientific misconduct. This story sort of reminds me of the perioperative beta blocker fraud saga. I mean, just the other day, a colleague asked whether we should give a patient preoperative beta blocker. I'm like, no. The decrease trials had major discrepancies and much of their results contained mathematically implausible data. And the lead author of Decrease, Don Poldermans, has resigned his post at Erasmus University after an investigation there confirmed numerous breaches of research misconduct. But yet, the New England Journal of Medicine has not retracted the Decrease 1 trial. And that's a problem because if a trial with so many questions remain published, it gives one the impression that policing scientific misconduct may be less than robust. Next topic concerns cybersecurity of cardiac devices. Quote, to date, Medtronic has received 0 reports to indicate an individual with malicious intent updated Medtronic devices with non-Medtronic software. But, and note the passive voice here, vulnerabilities have been identified in the software download process. These sorts of hacking concerns has led Medtronic to disable internet updates for its CareLink programmers. New software updates need to be made with a USB stick obtained from a Medtronic rep. My friends, There's a lot to worry about in this world. I mean, there's cancer, heart attacks, there's dementia, there's being maimed in an auto accident due to distracted driving, being bullied on social media. But hacking of cardiac devices is simply not one of these things we should worry about. I feel the same about this alert from Medtronic as I did from an earlier one from St. Jude Abbott. It's silly, and I wish we worried about more clear and present dangers. One thing that I truly hope these alerts don't lead to is lower rates of adoption of remote wireless monitoring. Remote monitoring of these devices has been a big benefit to patients with cardiac devices. The final topic today concerns bariatric surgery. Obesity is surely a problem. Obesity is a problem because it can cause major adverse cardiac events, among other health issues. And trials have suggested that bariatric surgery compared with conventional therapy may improve cardiac risk factors, but no data exists on whether bariatric surgery can reduce actual events. Multiple public health and outcomes researchers therefore set out to study the association between bariatric surgery and outcomes in patients with diabetes and severe obesity. In this retrospective matched cohort study, the authors compared more than 20,000 surgical and non-surgical patients from about 2005 through 2011. The surgical procedures were done at 4 integrated health systems in the U.S. And the authors matched the non-randomized groups on many different clinical factors. Clinical factors, of course, that can be gleaned from a database spreadsheet. And they found, not surprisingly, a strong association between lower rates of major adverse cardiac events in the surgical patients. The relative risk reductions were in the range of 40% lower rates of macrovascular events in the surgical group. Now, while the author's second sentence of the conclusion say these findings require confirmation in RCTs, they then go on to say in the very next sentence that clinicians, quote, should engage patients with severe obesity and type 2 diabetes in a shared decision-making conversation about the potential benefits of bariatric surgery for the prevention of major adverse cardiac events. Now, my comments begin as like, my gosh, where can I even begin with this? First, I am open to the possibility that bariatric surgery could lead to real cardiovascular benefits, not just better risk factor numbers, but better outcomes. But this sort of study can never answer this question. Why? Because we simply don't know whether the rates of cardiac events are lower in the surgical group in this study because of the surgery or because healthier patients get surgery. I strongly suspect selection bias in that healthier patients get surgical therapy. And of course, the attempts at matching can't replace true randomization. The second point is I am also all for shared decision making. But what exactly should we say to patients about an immensely limited and confounded observational study? To suggest even a potential cardiovascular benefit on the basis of this sort of study implies making causal inferences, which we simply should not do. Third point, this is a perfect example of why journal editors need to force a paragraph on limitations in the abstract, not just in the discussion section of the paper. Now, to the author's credit, they do list 6 limitations in their discussion, but still, the editors need to disallow causal claims in the abstract or conclusions. This sort of data can only do one thing, and that is to stimulate randomized controlled trials to definitively answer the question. Finally, how is it that payers and regulators have allowed the surgery to proceed in earnest without RCT-level evidence that it improves more than just cardiovascular risk factors? Given the fact that bariatric surgery is expensive and invasive and potentially harmful, I would ask, why don't we have stronger evidence that this surgery actually improves outcomes? And this sort of non-randomized observational database type of work does not answer those questions. So that's it for this week in cardiology. I'm grateful that you listened. Thank you. Again, remember, if you like this podcast, please consider subscribing or giving us a good rating. It helps people find the podcast. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org on Medscape.